Hey everybody, Sean Haverson here. Thanks for joining me for another episode of Exploring the Human Body for Paramedic students. Now, today we're going to talk about a really important system that I don't think gets the credit that it should. I would say that the endocrine system, since it isn't a single organ, we definitely don't put into our list of the big three, but it should be. The big three won't work if the endocrine system is not functioning. So let's dive in. If we boil down all of its parts and workings, it's going to be a chemical messenger system, and it utilizes hormones to do its job. Hormones are chemicals, and they'll go from an area where they're stored and released and travel to a different part of the body where they'll have an impact on an organ, a tissue, a cell, or all of those things combined. Well, we've already talked about a messenger system, right? We talked about the nervous system. If we're saying that there's a message to be sent in these two systems, then if the endocrine system is a chemical messenger system, we've already learned that the nervous system is an electrical, or I guess you could say electrochemical messenger system. Let's explore that a little bit. Right? Remember that as an axon of a neuron travels through the body, the brain, wherever it's going, while it's getting ready to do work, it's going to have a more positive charge on the outside of the cell than on the inside. So just like a battery, we have positive and negative sides. Now, polarity means that we have opposites. Positive is opposite of negative. This was achieved by sodium primarily being pumped out of the cell at a different rate than potassium is going in the cell. Right? Refresh, we got that. Once we need to send a signal, the message is essentially going to be an electrical change where now the inside of the cell is more positive than the outside of the cell, and that causes a neurotransmitter to be released. The neurotransmitter is then attached across the synaptic cleft to what we probably learned most recently, a muscle cell or whatever other cell, including another neuron, and that causes the muscle cell or other neuron to reverse its polarity. And if we were talking about the message being, I want you to pick up that weight right there so you can lift weights, then that was a contraction. The message was contract the muscle, right? Now, although chemical, it was primarily a means of electricity because of our chemical ions electrical charge. So let's keep the electrical part of it as our core point for the nervous system, and chemical is how the electrical gets there. Well, the endocrine system doesn't have an electrical component for all of its processes, but it works very closely. In fact, neither one of these systems is going to do good for our body if they're not both working effectively. So in the way that we are thinking about these signals, let's say that if we have a neuron depolarizing and sending the signal to the muscle cell to contract, it's probably got to be pretty quick, right? A matter of probably nanoseconds. So that's a very, very fast message to send. So the nervous system is like sending an email. That email that we type up is not a physical thing, right? We don't have a physical system that it's going to circulate in. It's basically us typing through a physical thing, a precise collection of electrons that then travel through the wires, through Wi-Fi or whatever, and then are received at the person that's receiving the email's terminal, and they open it up, and that collection of electrons that wasn't in the same organization as they are now suddenly creates a message that we can understand. So that happens almost instantaneously. So if email is how we send the message in an analogy for the nervous system, then the chemical messenger system is just like using a letter. This is physical. These are things that have to be sent through a physical system, and they go through all these different structures that aren't made for that specific system, but we take advantage of, right? What I mean by that is you write up the letter, and you use your own power, using your nervous system and your muscle, to get yourself down to the mailbox, and you put it into the mailbox, and the mail carrier picks it up, and they drive it around on the highways, which aren't designed necessarily just for mail, and then it goes into somebody's post office box or whatever, right? So that's a system of tools like our vehicle, our roadways, that this message is going to use to travel that aren't intended directly for that purpose. Well, very similarly, the endocrine system is sending a chemical message. So it's a hormone, which is basically an independent chemical structure, and it's going to travel through our blood vessels from wherever it was stored. It's going to make its way, impacting different organs, and eventually it will reach and have an impact on the tissue that it's meant to work with. And when that signal is sent, very often it's sent in some coordination with the nervous system. So the nervous system is basically directly connected to the endocrine system's virtual network in that sense. So when thinking of these two things, I think it's very easy to break them apart and say chemical versus electrical messenger systems. And then we got to add another concept here that I think will help you in areas maybe even outside of the endocrine system. All right, so I'm going to go on a little tangent here, okay? And I want to talk about a concept that I've recognized in emergency medicine. And this is a concept that the body uses, that our medications, since they impact the body, follow, and even some other simple processes that we use in treatment, okay? That method is, if something is easy come, something is also easy go. What do I mean by that? Well, if something happens really quickly in the body, it probably doesn't last long. Let's try that theory. So we're talking about the endocrine system, right? So let's go ahead and talk about something you already know in the endocrine system. That's diabetes. Diabetes is an issue in which the sugar is not getting to its end point, and that can be for a variety of reasons, aka types of diabetes. But the sugar itself is not all created equal. So when we're talking about sugars, I like to use the analogy of building a fire. The analogy of building a fire involves us basically finding fuel, twigs and sticks and logs, and that fuel is ignited, and using oxygen, it oxidizes and creates a fire. And that fire releases heat through the process, right? Follow me on that. All right, so if I'm building a campfire, and I've got these big old logs, and I need to make this fire last all night because it's cold outside, I could take a little match here and light it, and it ain't going to do nothing to that log. That log is not going to start to burst and go into combustible flame, right? So it needs actually more heat over a longer period of time for it to get engaged. But if we heat this up for a longer period of time, even though it doesn't happen right away, it will last longer. Well, how do we get to that point? Well, we start finding other types of fuel, like we're going to now work on some different sticks. And we'll probably find kindling, right? Grass, dry material, something that is a very kind of not very dense object that a match or lighter can then set aflame pretty easily. So if it's easy to get kindling on fire, does it last very long? It doesn't. So it's easy to get on fire, but it's quickly used, right? But we use enough of this to then ignite, not the log, because kindling won't last long enough to ignite the log. We use it then to ignite the sticks. Sticks take a little longer. You could potentially hold a match there and get a stick to light, but it's probably going to take longer than the kindling. So we're going to say this is like our medium fuel, and it lasts a medium amount. Doesn't last for very long. However, it's going to create enough energy that if we have a log now stacked on top, right, we got our logs stacked up around our campfire. If we have that set up, the kindling on the inside, we light the kindling first, that gets hot enough, then it ignites the sticks. The sticks then burn a little longer than kindling does and create more heat, and that sets the log on fire. So in this case, the thing that was easiest to combust, the kindling, is the easiest or the quickest to go away. Now let's think about that in the human body. If we're talking about the endocrine system and we're using kind of an analogy with our fuel for a campfire as an equation to talk about sugars, then we have complex carbohydrates, right? Here's my sandwich. If you like orange lettuce on your sandwich, that's a complex carbohydrate. It has starches in it. It has fibers that are probably plant-based. And so those fibers are a little bit harder for us to digest. So we have to rely on kind of complex mechanisms to get it going. And then we have little tiny granules, crystals of sugar, right? And then something like a solution in between. Well, when the body is trying to find sources of energy and to use them, it's going to most readily, easiestly, in the fastest means, it's going to use the simple carb fastest. And we know that because we use very simple oral glucose at the basic level to get a person's blood sugar to go up. But we know that if that's the only thing we use, they may have a reversal of their symptoms and start acting normally, but this is used pretty quickly. So, easy come and easy go. If it takes a while to get started, it will last longer. Is that true? Well, let's look at this. The syrup will last a medium amount, but then when we get to the complex carbohydrates, let's use maybe even a baked potato, right? We use a complex carbohydrate. Our body doesn't take this and convert it into sugar immediately, right? That it can use to fuel our cells. It takes a while, but in taking a while, it lasts longer. Back to what we were talking about initially, when we're comparing these systems, when we're dealing with our nervous system, that's like the kindling. It sends a signal almost instantaneously, and it doesn't last long, though. And the endocrine system is then going to be our log. It's going to have a little bit slower onset in some cases, comparatively. If it takes a second for a hormone to impact a cell, but it took nanoseconds for the nervous system to impact a cell, certainly it's definitely a difference in time, but we don't always observe it that way. So when we give medications, we have hormones that we're going to give in emergency medicine for patients. And we also have chemicals that will cause other hormones to do something. We have a lot of different angles to attack this. So now when we think about our body doing something, we now need to think about not just the nervous system causing and receiving information, but the intermediary step of the endocrine system communicating with cells in the body that aren't directly connected to the nervous system. All right, thanks for bearing with me on that analogy and explanation. Let's move forward. Okay, so the endocrine system is made up of a bunch of different structures, organs, and tissues that, as I mentioned earlier, are not actually its own tissue. So it's not like we're looking at one organ and can say, all this stuff happens in this organ. This happens by using other organs that do other things and impacting them in different ways. So when the endocrine system is activated, the endocrine system is releasing hormones into the bloodstream that will probably travel around the body and have an impact on at least one cell, but probably also impacts on other cells. Now, to break down the term, when we see the term endo generally means within. If you have an endoscopy, they have inserted a camera generally in the upper GI tract. Now, we do have glands that are not endocrine system glands, so we need to make sure that we're considering that. We'll talk more about those when we talk about the digestive system. So the endocrine glands are generally ductless. They don't have that conduit. They're using the blood. And when we're talking about the hormones themselves, hormones can have a variety of impacts depending on which cells they impact. And we have many subclassifications of hormones as well. So this picture here is showing both the male and female organs associated with the endocrine system. So the brain is not the endocrine system, right? It's not the only thing the brain does. It's the nervous system. So the endocrine system is working with the brain, a system that's different from itself to achieve a goal. The thymus, both in male and female, is a independent organ that is associated with the endocrine system, but it also has an impact on our bloodstream and on our ability to work with inflammation and healing. The kidneys, they are heavily involved in the endocrine system. You probably know that already because of the release of the chemical or hormone, aka adrenaline. But the kidneys have a different role. Their role is to work on balance of fluids in our body, getting rid of waste, and maintaining our blood pressure. The pancreas has both endocrine glands and exocrine for digestion. So truly, we're dealing with a collection of independent resources to give rise to our goal. So I do want you to know for each of these organs where they're located, what their role is in the endocrine system. If these secrete a hormone, which hormone specifically do they secrete? And what are some major diseases associated with the hormone and the organ? Before we get to the organs and talk about their independent function, let's talk about the chemicals themselves. So we're in that granular, we've zoomed in, we're at a high level of magnification. We're looking at things that are subcellular now, and then we'll start zooming out. So we have two major classifications of hormones. We have steroid and non-steroid hormones. That's the first classification. So as you're learning hormones, you do want to know, is it a steroid or non-steroid? The reason that this is important is because they have two different pathways to activate the cell and tell the cell to do something. Also, many of our medications can fall into one of these two classifications as well. So understanding this basic mechanism will help us for pharmacology later. All right, so the basic idea of a steroid hormone is that the steroid hormone circulating through the blood after it's been released from its gland is then going to have an impact on the cell's function by going into the cell directly. Now, the non-steroid hormone doesn't do that. It causes the cell to change by attaching to the outside of the cell on a receptor site, and that triggers something inside the cell to change its activities. Some of the hormone types that we've talked about that fall into steroid versus non-steroid are kind of easy to highlight. So steroids are really going to only be associated with one set of hormones, and those are associated with aldosterone, testosterone, and cortisol. And the derivative, or an important component we could say of steroids that's not part of non-steroids, is cholesterol. Now, all the rest of these types of hormones are non-steroidal. So just to catch that slide a moment ago, steroids impact DNA directly. Non-steroids use a secondary system to impact the cell. We'll get into all of these types of hormones and individual hormones a little bit later. You will want to be able to identify, is this hormone an amine, a glycoprotein, a peptide, or a protein, and is it a steroid? Let's look at that mechanism of action. Okay, so just pretend that we're talking about mechanisms of action the same way we talked about them in pharmacology at the basic level. The mechanism of action is how a chemical, a drug, a hormone, may be the same thing, but very similar. A chemical is essentially impacting the body, and the way that it impacts the body, the cell, the tissue is its mechanism of action, like at the cellular level. So the mechanism of action of steroid hormones and steroid hormone-based medications is the actual steroid, so here's our chemical signature, travels through the plasma membrane and then goes into the nucleus of the cell and causes the receptor site it's going to be binding on of a complex protein structure to then do something by reading the DNA and causing an output. In this case, it's creating a newly formed protein that we're going to use somewhere else in the body, or in that cell, rather. Okay, so steroid hormones go steroid goes straight to the inside of the cell, the nucleus, and have an impact there. Non-steroid actions are a little bit more complex. So what's going to happen is a combination of our hormone, get to the next slide, combination of our hormone, again, a chemical, being released from a gland, traveling through the bloodstream, making its way to the cell. This is the cell, okay? Now, I really like this picture because it's going to explain some concepts important for pharmacology later on. All right, so on the outside of the cell, let's say that our DNA, our nucleus is down here. That's where DNA is. Just to compare to that last picture we saw, the hormone is going to attach to the receptor site on a complex structure, a complex molecule that's embedded inside the plasma membrane. So we can call it a receptor site. What happens when it attaches is it will cause a glycoprotein, that's what this G protein is right here, to change its shape. So the glycoprotein, we can think of this as being next step, the glycoprotein then has the ability to use this lends an ACE, so this is an enzyme, to cause an enzyme to do work. And the result of that enzyme's component in chemical reaction is the thing that changes in the cell. That's what the work is, or whatever it is we're trying to do in the cell. So as the process works, we say that our non-steroids have a secondary messenger. The first messenger is the hormone coming from the originating gland, secreted through the bloodstream and making its way to the cell. That's the first messenger. And then another message is created. The secondary messenger is inside the cell. So what's occurring here, this is a very simple example, but it uses, after we've activated the glycoprotein and activated the enzyme, it's going to use ATP through a pretty complex process to create cyclic AMP. So let's just kind of work on that term real quick. So ATP is 3 phosphate ions. ADP is 2 phosphate ions. So AMP, mono, is 1 phosphate ion attached to it. So adenosine monophosphate, cyclic, in this case, cyclic adenosine monophosphate is a result of ATP being changed by an enzyme, and cyclic AMP acts as our secondary messenger, and in this case, it's going to cause a protein enzyme to turn on and activate a protein. And just imagine that this then goes to have an action. Okay, so in that process, our non-steroidal hormones use a primary message of our hormone, sending a signal to be read by the receptor site. The glycoprotein attached to the receptor then has an action of splitting, in this case, in two, activating another enzyme that causes a chemical reaction inside the cell. The inside of the cell sees ATP, in this case, converted to cyclic AMP. And by the way, cyclic AMP is going to be part of many of the medications we talk about in pharmacology. And cyclic AMP becomes our secondary messenger. Its message is to turn on or start a process in the cell, in this case, taking an inactive protein and using an enzyme then to make an active protein. And that active protein will result in the action that's desired from the cell. All right, shake and bake. Let's go. Okay, so in order for us to understand the diseases we need to get to talking about at the end of this, we do want to understand kind of the normal processes of the body. So a phenomenon that occurs in the body that you have heard a little bit about before is very often associated with hormones and the endocrine system. So we have a feedback system in our body based on hormones, and we can classify the feedback system, which is essentially a stepwise process, as either being a negative feedback or a positive feedback. The negative feedback is an example of process that happens many different times in many different ways inside the body. But the positive feedback system has less examples associated with it. So what I would do if I was you, I would think about these in memorization tools as thinking, I'm going to memorize the positive feedback, and then if I'm presented with something that says it's a feedback loop, if it's not positive, then it's right, you got it, negative, right? Okay, so there's basically, depending on the textbook you read, there's two types of positive feedback. Our textbook says there's one, but I'm going to give you both just in case. We could think of a positive feedback loop as being an amplified process, right? It's a loop, so it eventually turns on and turns off. The positive feedback is an amplified process in which this thing, this process, this system, is going to work harder and harder and harder, maybe faster, 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 but it's going to amplify its effect until it can no longer do so. And in no longer doing so, that's when we reach our goal. So a really good example, I think, of positive feedback loop is going to be the contraction in the uterus during labor. Think about how labor contractions come about. When the person goes into labor, and they enter into the stages of labor, the first stage of labor is marked by the onset of true contractions. And what happens with contractions over time, right? This is important for you to know because this will make a big difference as to, do I do this right here and deliver the baby in the home and at Walmart? Or do I have time to get in the truck and transport to the hospital where it's a much better environment for a child to be born? Well, that distinction is going to be partly based on how are these contractions progressing along. So contractions generally start off, so we'll say start, and they end basically with delivery. They start off being further apart and not being as strong, to then happening more quickly, more frequently, and being stronger, stronger, stronger until the child is born. So you can see the contractions started off and amplified their intensity as they got closer to the end of the process. Another positive feedback loop sometimes is considered in blood clotting. And we'll talk about blood clotting at length in the blood lecture and in your pharmacology class as well. If you just use labor as your positive feedback loop, that's perfectly fine for our purposes right now. And if it's not labor then, and not in some textbooks blood clotting, then it is negative. So an easy way to memorize the impact of a negative feedback loop is to say that a negative feedback loop is going to occur by having something needed to occur. There's an action, some process that has to happen, and it will do so until it's negated. Till it's negated. What does negated mean? Basically means that it's turned off. It's irrelevant at that point. So a negative feedback loop is going to involve a process that occurs until the process is essentially turned off or negated. So let's look at some examples. It's probably really helpful for us to start thinking about negative feedback loops in two major ways. One would be how our body deals with thermoregulation, and the other will be how our body deals with food intake and sugar. Let's start here with thermoregulation. So thermoregulation means the regulation of our body's temperature. We do so by a pretty predictable thing, and all of us have experienced this, and actually we probably can tie this together really easily once it's explained. So what I want you to imagine here is that in our house we have a thermostat, but this thermostat isn't like a New Mexico thermostat. New Mexico thermostats, if you got a swamp cooler in New Mexico, you probably have a thermostat for the swamp cooler and then a thermostat that's separate for the heater. Imagine that we got a really nice cooling and heating system, and so it's all in one. If we set the temperature to be 98.6 degrees in the house, one thermostat will either, if the temperature goes below 98.6, cause heating, or if it goes above 98.6, cause cooling. Okay, follow me on that? Well, where is this located? Where is this thermostat located? So it's essentially inside our hypothalamus. The hypothalamus is a very important structure within the brain that is essentially the origination of most of the communication between the brain, our electrical messenger system, and our endocrine chemical messenger system. So what's happening is our body is measuring the temperature of blood in different regions of the body, and that temperature basically is the input for the thermostat. That's the thermometer. So what happens is our thermometer is generally set, as you know, to a range that has a midpoint, an average point of 98.6 degrees Fahrenheit. So what ends up occurring is some structures inside the brain, inside the hypothalamus, are going to be measuring this temperature. And when the temperature changes, let's talk about heating first. When the temperature changes, if it gets cold outside, our body can do a few things to work on our temperature regulation, to try and preserve our core organ function by maintaining an optimal environment of temperature on the inside of the body. So let's say that we have our temperature going down, so it's set for 98.6 degrees, it gets cold, our body then says, let's turn on the heater, right? So as this heater works, it's going to send a signal by using an electrical impulse to stimulate the release of hormones in the brain. Those will be circulated through the bloodstream, and a few things happen. We're going to have, our body will turn on its heating mechanism by causing shivering, by causing shunting of blood, right? Blood is going to be shunted by peripheral vasoconstriction, making the blood go away from the outside of our body, our skin, the muscle around soft tissue. All of that is going to be basically shunted of blood, and the blood will be brought internally so that we have better control. The outside environment will have less impact on the blood that's circulating in our core structure. So shivering was producing heat, as we see here. Shivering was producing heat in the sense of causing muscle contractions to occur. They're not gross motor contractions. They're very finite, uncoordinated motor contraction, meaning they're not happening in all fibers at the same time like we usually would have. And in that process, it's needing energy, and the process of getting energy to the muscle is to create heat. So those two mechanisms start to turn on. And as the temperature goes up, let's say we got down to 80 degrees, being a little drastic, but we get down to 80 degrees. As the shivering and shunting occurs, we start going up. Eventually we reach 90. Then we get to 98. Then we get to 98.6 degrees, and the thermostat says, stop heating, right? It negates the heating process. There's no need for this to happen. It literally turns off the process, and we no longer are telling cells to vasoconstrict in the periphery, and we're no longer telling cells to cause shivering. Follow me on that? Okay. Now, if we went too far, we heat up and we end up having a body temperature increase, sometimes that's for a tolerable reason. Maybe that's because the patient has a fever. But let's say that we just left the heater on in the house impacting our body, and we set it because we were really cold for whatever reason, like 90 degrees, and we're not paying attention. The body stops shivering, and now we're at 98.6, and then it keeps going up. Our body temperature goes up to 100 degrees because of biological processes in the ambient environment. Well, at some point, the body should say, whoa, 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 that's a little too high. Let's turn on our cooling mechanism. And our cooling mechanism is going to involve, just like a swamp cooler, it's going to involve opening up our blood vessels so the heat that's in the blood can make its way to the outer region of our body, the skin and soft tissue. And in that vasodilation, the blood cells are going by that region more quickly through the process of sweating. And the sweat taking heat on, the actual fluid and sweat on the surface of our skin, takes heat out of the bloodstream. Remember that water is going to absorb heat at a much better ratio than just ambient air. And it's taking that heat, and then eventually it dissipates and releases the heat into the environment as it evaporates. Well, that happens until our body temperature goes back down. And when our body temperature goes back down, theoretically, once we meet the point, the thermostat turns off the cooling mechanism. So through that process, us becoming warmer, us becoming cool, or basically reaching the midpoint again, is what negates this negative feedback loop. All of that is essentially coordinated by use of the endocrine system. All right, now we can start working on the structures and disease. So we're going to zoom out essentially now and talk a little bit more about the process and the structures involved in the endocrine system. When we talk about diseases, though, the endocrine system's role, remember, is essentially to secrete hormones. And so that would mean that if it's variable, it's not a standard amount of hormone every single time, it's variable based on the body's needs. So through that process of secretion, we can have too much secretion of a hormone, too little secretion of a hormone, and those will cause imbalances. You don't have enough of a hormone to cause this thing that your body needs to do right now. Well, that's hyposecretion. Now, there's a third type, though, and it doesn't actually have to do with secretion. So secretion means the hormone is produced and released into the bloodstream. But that's not the whole process, right? We also still, for this thing to work, hormones have to travel through the bloodstream and then be received by the cell that's targeted to work through. Well, if the hormone is working normally, whether it's a steroid or non-steroid, it should cause an effect reliably. But if we have created the right amount of hormone, so it's not hypo or hypersecretion, but the cell doesn't function, it's likely because of a target cell insensitivity. That could mean something like the receptor site for a non-steroid hormone has been degraded, destroyed through maybe an autoimmune disease or inflammation, many different ways that this can happen. Let's use an example very quickly that you already know about, though, just to underscore what these things are. And then as we get through this, my challenge to you is for each organ that has glands that release a hormone, I want you to know what happens in hypersecretion syndrome, hyposecretion syndrome, and target cell insensitivity, if applicable. Meaning, I want you to know what that disease is, what disease it's causing when that occurs. So let's look at diabetes again. So diabetes here we're talking about is blood sugar diabetes, right? And so when we have a patient that's experiencing diabetes issues, we can have that patient in diabetes type 1, with the Roman numeral means that it's probably insulin dependent. Insulin is the hormone that we're talking about in this phase of blood sugar control. So generally what happens in type 1 diabetes, insulin is not being created at all and secreted into the bloodstream. Secreted in the bloodstream, or it's not enough insulin to meet the patient's needs. So in type 1, I, for insulin, the problem is hyposecretion of insulin from the pancreas. That's a disease. Now, diabetes type 2, often called adult onset diabetes, is a different process. If the patient has truly just diabetes type 2, then they're creating enough insulin. That's not the problem. The problem then is on the cells where insulin attaches to its receptor site to function as the key to open the door. So target cell insensitivity is talking about a problem at the other end of this process. Hypo or hypersecretion is on the starting end, the secretion end of the endocrine process. Target cell insensitivity is on the receiving organ, cell, or tissue end, and that's a lot of ends, right? What would happen then if we have a patient that has type 2 diabetes and they have target cell insensitivity and we give them a bunch of insulin? Will that make that cell that has damaged receptor sites work better? It will not. And so the problem, the underlying problem, is in some cases really important for us to know because it'll lead us to a solution. So what's different between prostaglandins and hormones? Well, these are hormones, but they're tissue-level hormones. The hormones we've talked about so far have all been released into the bloodstream, right? So that means that they are circulated systemically, right? Now, prostaglandins are a little bit different. They are a chemical messenger. They function, they're a chemical structure that has a function in a cell, but when released, prostaglandins don't circulate through the whole body, not necessarily all of them. So these are hormones that are communicating a chemical signal within specific tissue, and think of that as basically being the boundary for these prostaglandins. Now, prostaglandins are involved in disease processes that we work with all the time in emergency medicine, and we actually do influence prostaglandins when we're using things like our medication treatment. So there's a few different types of prostaglandins. So if we say prostaglandin as a category is a bunch of chemicals that are within tissue functioning as a hormone, then we can break them down into different types of prostaglandin, and they have different effects on different organs in the body. So prostaglandin is generally going to be classified into prostaglandin A, or PGA, prostaglandin E, or prostaglandin F. And these prostaglandins can have the same chemical structure in different organs and sometimes cause different types of tissue responses. This is a nice little chart, and so let's look at one that's extremely important, PGE2. PGE2 is in many different types of structures in the body. PGE2 is associated with inflammation processes in the respiratory tract, GI tract, and in vessels and platelets. In fact, let's say that we've got a platelet cell, right? Inactivated platelet cell. That platelet cell, when it doesn't need to do any work, is going to be really slick and slippery. That's probably what you learned at the EMT basic level when you learned about aspirin. Well, when there's damage in the body and our blood vessels signal that there's damage or some type of injury, the inflammatory process will turn the platelet not from a slick, smooth surface to a really sticky surface. And that activation is important because now that it's sticky, other platelets will come by and start to develop the beginnings of a clot. Follow me on that? All right. Well, I'm not going to cover the entire process here and now, but when we're talking about drugs like aspirin, drugs like ibuprofen, many drugs that fall into this classification are anti-inflammatory. So when a patient is taking say we give, rather, the patient aspirin when we suspect that they're having an acute myocardial infarct, what we're doing is we're causing aspirin to come in and stop the process of unactivated platelets from activating. And in the zoomed-in view of this, what's happening is prostaglandins are responsible for taking this chemical, taking this cell and converting it into its sticky and active form. So that process essentially can be halted if we give a drug that stops the prostaglandin from having its effect. Okay, now we're at one of the most important structures in the body, important structures in the nervous system, and probably the most important structure associated with the endocrine system. That's going to be the pituitary gland. Pituitary gland is located in our central nervous system. It's associated with the hypothalamus, which is hypo, below the thalamus, and it's a coordination center in which our neurons, our brain, central nervous system, is going to be able to actually communicate with the chemical messenger system. It's the link between nervous and endocrine systems. So the difference here first is to say that we have two different types of hormones that are released, or two different structures that release hormones. One's anterior pituitary, one is posterior pituitary gland. the structural makeup of the pituitary gland is different between the anterior and posterior. The difference on the anterior, let's start there because the vast majority of hormones that are released from the anterior pituitary gland. And a side note, notice that we also have hormones that are released here that don't actually directly communicate an action inside the target cell. Some of these hormones released in the pituitary gland as our master gland are then going to communicate with other glands in the body that release the active hormone for our target cell. More on that in a little bit. So the difference is that when we're talking about the hypothalamus, we have axons traveling from the hypothalamus into the anterior pituitary gland where they interface with another structure, the gland itself, that releases the hormones. Okay? So the anterior pituitary hormones are not released directly from the axons of the hypothalamus. But the axons of the hypothalamus connecting to the posterior pituitary gland actually release directly antidiuretic hormone and oxytocin. So it comes from the axon. It's not the axon of the hypothalamus, as is in the anterior system, communicating with another structure to release the hormone. It does it directly. That's pretty fascinating that chemical, or these two chemicals rather, are released directly out of the neuron, and then they circulate through the bloodstream and will have an impact on structures in the body. Almost everything else is going to use a system in which there's an intermediary gland between the release of that hormone and the structure telling the gland to release the hormone. So these major hormones I'm going to list here are the hormones that I want you to really focus on, making sure you understand where they come from, what their action is overall on tissue, and what happens if we have hypo or hypersecretion, and in some cases, target cell insensitivity. That's the challenge. Let me go through these very quickly. When we're talking about our body releasing things like norepinephrine from the adrenal cortex, from the adrenal gland rather, the intermediary, the hormone that isn't active and causing the body to respond directly, but does cause the active hormone to be released, is adrenocorticotropic hormone. So when we say adrenocorticotropic, adrenal gland, cortico, cortex, tropic means that it's in the middle. It's not active. Tropic, when we hear that term as a hormone, tropic means that it's going to cause an active hormone to be released. Right? That's what I mean by intermediary. Growth hormone. Growth hormone is going to be released from the anterior pituitary gland, and it's going to have an impact on muscle development and bone structure development early in our life, and can have some consequences if things happen to this gland later in life as well. Don't worry so much about MSH. We're not going to do a whole lot with that in the paramedic level, but we will work with thyroid-stimulating hormone. Thyroid-stimulating hormone is actually another intermediate hormone. It is going to travel from the anterior pituitary gland to the thyroid, and the thyroid, through a chemical process, as long as all the components like iodine are present, will then release an active hormone. The thyroid-stimulating hormone does exactly what it says. It stimulates the thyroid to do more work. And in doing work, the thyroid is going to release hormones that cause our body's metabolic rate to increase. More on that later. Now, gonadotropins. Okay, so remember, if we hear something like tropic, it means that it's, in most cases, intermediate. And gonado is referring to the gonads, or our sexual organs. Our sexual organs for male and female, male testes, female ovary, and they will then release their own substances, including estrogen and testosterone. Finally, prolactin. We generally learn that kind of along with our gonadotropins and oxytocin. It works, prolactin in its term, it promotes lactation, right? Promotes lactation, prolactin. Oxytocin and prolactin both have impact on other structures in the body, but in their normal function are usually associated with female reproductive system and female glands within the breast structure that will secrete breast milk. And then finally, with oxytocin, our other posterior pituitary gland hormone is antidiuretic hormone. Diuresis is reflecting on the idea that we increase the release of urine with diuresis. Okay, so peeing. More appropriately, probably talking more about creating pee. But antidiuretic hormone stops us from releasing our urine. And now you may not know why exactly that happens, but the benefit of having our body not release urine in some cases is to retain fluid in our bloodstream. Even if it's still retaining some waste, we lose a lot of water through urine. So if we need to maintain our blood pressure, we may want to hold on to the water and not release it out of the body. If we release it out of the body, we lost water that would have made up plasma in our blood and would contribute to our blood pressure. Okay, so recapping, talking about our anterior pituitary gland. The anterior pituitary gland has neurons from the hypothalamus that will connect to a gland releasing the hormone, and then it enters into the bloodstream. Those hormones include, most importantly, adrenocorticotropic hormone, which is going to circulate through the bloodstream, be received by the adrenal cortex, and release our release our next active hormone, hormones like norepinephrine. Growth hormone released from the anterior pituitary gland is going to have an impact on muscle and bone growth, especially during development, but also has an impact on muscle and bone growth later on in life. We're going to skip MSH. Thyroid stimulating hormone is released by the anterior pituitary gland, will circulate through the bloodstream until it gets to the thyroid. It's inactive, but it causes the thyroid itself to then, if it has the components it needs, create an active hormone that will cause our metabolic rate inside cells throughout the whole body to change. Gonadotropins, I didn't necessarily highlight them. Follicular stimulating hormone and luteinizing hormone are both gonadotropins, and they're going to have an intermediate effect. Gonadotropins are going to have an impact on releasing other hormones like estrogen, testosterone, and more than that as well from the gonads, or our sexual reproductive organs. Prolactin is released from the anterior pituitary gland, but it works with oxytocin to have a few different roles, but one of the normal roles is to increase the production prolactin, promote lactation of breast milk. And finally, antidiuretic hormone released from the posterior pituitary gland is going to influence our release of urine and can be a component in maintaining normal blood pressure. The antidiuretic hormone has an impact on diuresis. Diuresis is essentially the process of creating pee. All right, good. So we've got the gist of those things. Let's dive in and learn a little bit more. So we're going to go into the functions really quickly. There's a table inside the Patent and Thibodeau textbook that you can utilize to help you kind of clarify these. I always recommend for rote memorization, I think making your own table and writing it all out and then quizzing yourself on the table is a really good tool for most learners in memorizing stuff that's purely cognitive and not necessarily a process. All right, so let's go through it. So as mentioned, thyroid stimulating hormone released from where? Anterior pituitary. Causes the thyroid gland to essentially, using components, secrete the active thyroid hormone. We're going to get into details in a moment. Adrenocorticotropic hormone, anterior pituitary gland secreted. It's going to the adrenal cortex, in which it stimulates it to release glucocorticoids. Now, cortisol is basically our primary example of glucocorticoids and is what we generally think of when we're talking about steroids in medicine and steroids associated with our nervous system's sympathetic nervous system. Follicular stimulating hormone, this is kind of a complex hormone, but what it does is it's going to cause follicular stimulating, anterior pituitary, the female ovarian follicles, follicular follicles, to release and start the process of ovulation. Now, follicular stimulating hormone is essentially a gonadotropin, meaning that tropic, it's an intermediate, so it will stimulate estrogen secretion in developing follicles, and in the male, it also works by stimulating sperm production in the male. Luteinizing hormone also, you guessed it, anterior pituitary gland. This is another gonadotropin, and luteinizing hormone is going to have an impact on luteinization of ruptured follicles. It has an impact on, since it's a tropic, another hormone activating, it's going to impact progesterone secretion and cause interstitial cells in the testes in male to secrete testosterone. That's the active hormone. Excellent. Growth hormone, yep, anterior pituitary. Growth hormone is going to influence our body physically growing those structures. So if the child has hypersecretion of growth hormone from the anterior pituitary gland, maybe they've got a tumor there or they have excess cells that release the growth hormone working overtime, that hypersecretion can result in the person being a giant, being excessively tall, and their organs will also grow in this phase as well. So it's not just their external body size, it's going to be the organs in addition. Now, after we've created our bones and we've gone through bone maturity, our bones generally don't elongate and grow anymore. So what happens in hypersecretion later in life is primarily going to be an enlargement of internal organ structure. Organ structures can change in size mostly throughout the rest of our body. Internal organ structures can change in size, but our bone doesn't. So if the growth hormone is released, then we get in the adulthood, it's called acromegaly. Hyposecretion during childhood of growth hormone will result in pituitary dwarfism. Okay, and then prolactin, also associated with our gonadotropins, is going to work in concert with oxytocin, which is a posterior pituitary gland hormone, to develop after the child has been born secretion of breast milk. Okay, our posterior pituitary gland is kind of simpler in the sense of it only has two major hormones associated with it. So when we're talking about these hormones, most of the other hormones we've talked about, some of them we won't necessarily talk about again to much detail. But when we talk about the pharmacology, reproductive system, that gives us an opportunity to talk about oxytocin. We have a medication in the paramedic school practice in New Mexico called Pitocin, that is essentially oxytocin administered to a patient. And then antidiuretic hormone is not something that we necessarily will give, but there are everyday things that will impact the secretion of antidiuretic hormone. And also, it's a major component in regulating our blood pressure throughout daily maintenance roles and when we have diseases or pathologic processes occur. Now, when we're talking about hyposecretion of antidiuretic hormone, what's going to happen is if there's not enough antidiuretic hormone, then we will have no anti-component. We will just diurese. Diuresis is essentially creating volumes of urine, which can cause, unfortunately, our patients or ourselves to become dehydrated. Here's a fun fact for antidiuretic hormone. When a patient drinks, or we drink, this is probably for our adult tasty beverages here. When we drink alcohol, alcohol works to basically impact and cause hyposecretion of antidiuretic hormone. We have to pee. A good example of this is, have you ever had one of those nice refreshing adult beverages if you partake? And when you drink a beer, let's say you're hanging out with your friends and you have a couple beers, well, you know that if you chug those beers there, eventually you're going to have to make that trek to the bathroom because it's going to cause you to pee. In my era, we used to call that breaking the seal. Once you break the seal, once you go pee the first time after you've had alcohol, you're going to be going all night long. Well, the reason is that alcohol, when you're ingesting it, is going to cause the antidiuretic hormone to decrease its secretion rate, which will basically cause us to have to urinate, which is why drinking alcohol ends up having dehydration lead to the hangover. Okay, the final posterior pituitary gland that we'll talk about is oxytocin. Oxytocin is an important chemical for a few reasons. It's an important component of the natural process of labor and delivery. It's also, though, important for our use as a medication. When oxytocin is in the paramedic scope of practice utilized, we use it for postpartum bleeding. If after birth, after delivery rather, the woman is still producing a large amount of blood, generally that large amount of blood is quantified. Anybody know what's excessive postpartum hemorrhage? What volume? 500 milliliters is a tolerable amount of bleeding associated with delivery. It's going to be bloody because there's tissue separating from blood vessels at the very least inside the uterus where the placenta is attached to the uterine wall. So when we have a patient that has excessive uterine bleeding at the basic level, one of the things that you learned to do, hopefully, was that the child should immediately after birth, as long as we've dealt with any core organ dysfunction, child needs to be given to mother and should start suckling on the mother's breast so that they can initiate. One important part of it is maternal-baby bonding, and that happens immediately after birth. Also, that helps us wrap both mom and baby using mom's body warmth, skin-to-skin contact, and then wrap mom with blankets so that she and her body are keeping the baby warm. And finally, what happens when we stimulate through the child suckling on the breast is the release of oxytocin. And oxytocin will cause the contractions that after birth are going to help stimulate the blood vessels, decreasing the amount of blood they're producing so that we can get clotting to occur and stop the excessive bleeding that can happen. So that's released in the normal process of baby feeding on mom's breast. So it's important that we help promote that, even if the mom doesn't want to breastfeed later on in the process. Right after birth, we really need her to do so. So we can give that medication if we have excessive bleeding and we don't have a cessation of bleeding, even if we use something like our uterine massage, which is definitely not a massage, but the term we use at the basic level. So it's essentially a chemical means of giving that uterine massage. So another highlight. So remember that the actual chemicals, the hormones that are created in the posterior pituitary gland, are created inside the structure of the hypothalamus. Now they're released basically down the axon into the pituitary gland and then released into the bloodstream. Here's another diagram. You can see both our neuron innervation and blood cell innervation into the tissue. You can see that on the anterior, posterior pituitary, we have blood circulating in capillary form around the glands that are going to release individual hormones. So the hypothalamus communicates with the blood flow. That will also have an impact on the blood picking up and transporting away the hormones. But the hypothalamus doesn't create those structures independently. However, when we're talking about the posterior pituitary gland, the hormones are created in the hypothalamus and then travel through the axon, then to the capillaries and released into the bloodstream.